Hi, everyone, and welcome. I'm Ellen McNally, and I'm MD Everywhere Sales and Marketing Project Manager. For those not familiar with MD Everywhere, we are a single-source RCM and EMR solution provider with technology and best practice medical billing services that are proven to improve the claims process, decrease denials, and increase collections for our clients 10 to 15%. I do want to thank you all for joining us today for our webinar on Bundled Payment for Care Improvement, or BPCI. Our presenter is Dave Terry. He is CEO of Archway Health Advisors. Throughout his 20-year career in healthcare, Dave has been a senior executive and trusted strategic advisor for providers all along the care continuum. In these roles, he has led care and risk management initiatives with primary care physicians, specialists, acute care hospitals, pediatric health systems, skilled nursing facilities, home care companies, and hospice providers. And Dave is a thought leader and frequent speaker on bundled payments and other payment reform initiatives. He'll be sharing his knowledge with you today. Before I do turn the mic over to Dave, let's just cover a couple of housekeeping points. Just so everyone knows, this webinar is being recorded, and the recording will be shared along with a PDF copy of the presentation with all registrants via email. Attendees will be muted during Dave's presentation, but we expect you may have questions. We are leaving a little bit of time at the end of the presentation for your questions, so please type them into the questions chat window in the lower corner of your control panel as you think of them. We will follow up with them with as many as we can live on this call during the webinar. Any that we don't get to, we will reach out to you after the webinar and get your questions answered one-on-one. Also, we will be conducting 3 audience polls during the presentation today. It makes the webinar a bit more interactive. I will announce each poll as it comes up, and we'll also provide the results of the poll once the poll closes, and your participation is encouraged. It does contribute to the value of today's presentation. So without any further delay, I'm going to hand over the mic to Dave Terry, CEO of Archway Health Advisors, for his take on bundled payment for care improvement. Dave?
Great. Thanks, Ellen. And thanks to Ann Bill Yu and the team at MD Everywhere for putting this together, and to the folks who are on the line today. I am going to go through the bundle payment program, the opportunities for providers to participate, and why I think there are good opportunities for providers, and how the process works to get involved. Before I do that, though, I just want to cover two themes that I want to make sure that I leave you with today. One is that the bundle payment program really is designed for specialists, specialty physicians. Maybe you could go to, actually just go back to the previous slide if you would, Ellen. I'm going to have to ask Ellen to advance slides for me, so bear with me, folks, as I go through this. But the two themes are the bundle payment program is really designed for specialty physicians, acute care providers, and post-acute providers to benefit from the care and risk management initiatives that you're putting in place, and to earn the dollars, or a portion of the dollars, that you create by driving savings as patients that you care for, reduce readmissions, reduce post-acute costs, and transition through the continuum of care from hospital to home. There are other payment reform initiatives out there that I'll talk about, ACOs and others that are designed for other providers to focus on and to benefit from. But this program really creates opportunities for providers to access new revenue and to capture some of the value you're creating by doing that work you're doing on care improvement and care management. The second theme I'd like to leave you with is the timing is tight for getting into the program. The application deadline, or indication of interest deadline, to CMS is due on April 18th. But this is a non-binding indication of interest, and the information they're looking for is very straightforward and could be gathered in really a couple of days. So while there is a tight time frame, it's completely achievable to apply to the program if you're interested in moving forward between now and the deadline on April 18th. So with that, why don't we get started? Maybe, Ellen, you can go to slide 3, if you would. Next slide. So Archway Health Advisors, just a bit on our firm. We are a new firm. Our mission is to fix healthcare through payment reform. Not that ambitious, but I've been working in healthcare my whole career, and I think there's a lot of opportunity for improvement, and I think payment reform drives us in the right direction. And so our focus is to work with providers to fix healthcare through payment reform. Next slide, please. As I said, we do work with providers. We're provider-oriented folks. Our goal is to help design, execute, and finance care and risk management programs that fit with your capabilities and what's happening in your market. There are 4 things that we do when we work with providers. We provide basic advisory services. We help on high-level data analytics. We can help secure risk financing for programs, and then also help in thinking through care redesign so we can actually achieve improvement and reduce costs as we approach these risk management programs. Next slide, please. So what we'll walk through today is what the program is and how it works, what the benefits are to providers who participate, and for specialists as well as acute care providers. I know there's some acute care providers on the line. And then what are the next steps for moving forward? Next slide, please. So here I'll cover what the benefits are. And I think we have a poll at this point. Not sure if I should pause for the poll or keep going.
No, Dave, we're going to do the poll at the end of your talking points. We'll always do the poll at the end of your talking point.
Okay. Okay. Great. Okay. So let's go to the next slide, and maybe we can do the poll as we talk through that one. So as I mentioned, and as you know, there are a number of payment reform initiatives that are out there and that CMS has been implementing, and they're being implemented in the commercial market. But there have been several studies that have indicated that bundled payment seems to have the highest potential for significant impact on healthcare costs. And this is a study from the New England Journal of Medicine. There have been other studies by MedPAC and by bipartisan congressional committees that have indicated that the bundled payment does seem to have the biggest opportunity for improvement. And personally, I agree with that. Having managed in a global capitation environment and worked with many ACOs, I think global capitation has benefits and clearly has a role. But the focus of the bundled payment initiative is to allow providers, particularly specialists and acute and post-acute care providers, frankly, where a lot of the healthcare dollars are spent, allow those providers to focus their attention on the care and risk management needs of the patients that are under your care when those patients need your care the most. And so, I think PCPs have a clear role in participating in this process, but post-acute folks and specialists and acute care folks spend a lot of the dollars, and this program creates incentives for those types of providers to drive the care management activities and, again, capture the savings for doing so. Next slide, please. So here we have a quick poll. Okay, so this is very helpful. I've not done a webinar before where there's a poll like this. This is great. So I would say this is also pretty typical. I talked to a lot of folks about bundled payment, and what I find is that the bundled payment program has definitely received less attention than ACOs and other reform initiatives. But what I also find is that once folks learn about it, particularly folks who have care for a lot of patients who have a lot of cost or time in the post-acute setting, find it quite attractive to at least explore the benefits of the program. And so it's relatively typical to talk to a group of folks who know a little bit about it but are interested in learning more. So this is great. So next slide, please. Okay, so I'm going to talk a bit about the mechanics of the program and how it works for providers who participate in the program. There are 4 models, models 1 through 4. I am today going to focus on models 2 and 3. And the reason is model 1 and model 4 are really more focused on the inpatient setting alone, whereas model 2 and model 3 create opportunities for providers to manage patients along the continuum of care and achieve savings, achieve and capture savings for that period as they're managing those populations. There are some significant consistencies between how model 2 and model 3 work, and I'll walk through those. So in both cases, a bundle is initiated when a patient is admitted to the hospital. That's an event that has to happen to create a bundle. What CMS has done is they have taken 179 DRGs, enrolled them into 48 different bundles, and they've captured many of the high-volume, high-cost types of care, like major joint procedures, CHF, COPD, stroke, fractures. About a quarter of the costs are in orthopedics, and about a quarter of the program costs are in cardiology and cardiac surgery. And then there are some other high-volume areas like respiratory with COPD and pneumonia, GI, and some other areas. They've taken a significant amount of the CMS spending for patients who have an inpatient admission. About 70% of all the dollars that CMS spends for patients who have been hospitalized are eligible services within the bundle payment program. So they're focused on putting a lot of dollars into this program and creating opportunity for providers to participate in a lot of different ways. So in order for a bundle to start, the patient has to be hospitalized, and they have to have one of the DRGs that's in the program. In Model 2, Model 2 can be initiated either by a hospital or a physician organization, a physician group or individual physician. For a physician to initiate a Model 2 bundle, they're either the operating surgeon or the attending physician. And in Model 2, the bundle includes the initial hospitalization and all the costs that happen to that cost of services that happen to that patient over 30, 60, or 90 days. And as the initiator of the bundle, you can choose whether you want to do 30, 60, or 90-day bundles. In Model 3, similar scenario, patient's been admitted to the hospital, they've got one of the DRGs that's in the program, but the risk meter doesn't start ticking until the patient is discharged from the hospital. And in that case, the costs don't include the initial hospitalization or any physician services that happen to the patient while they're in the hospital, but they include all the costs that happen after the patient is discharged. And again, you can choose 30 or 60, 90 days time frame for how you want to approach the program. Costs that are included, in Model 2, it includes the initial hospitalization, and then it's pretty consistent between Model 2 and Model 3. It would include all the post-acute costs, so any skilled nursing facility or inpatient rehab costs, LTAC costs, home health care, physician Part B services, outpatient services like ER visits or physician visits or lab tests. Certain things, significant items that wouldn't be included also I missed readmissions. A major category of costs are included in both Model 2 and Model 3 or any hospital readmissions. And most readmissions are included. There are a few exceptions that I'll talk about in a moment, but most readmissions would be included. Two major exclusions to keep in mind: Medicare Part D drugs are not included. Hospice is also not included in the cost of the bundle. But most things are included, and you can choose between Model 2 or Model 3. As I mentioned, Model 2 is initiated either by a hospital, so the hospital can be the owner or the initiator of the bundle, or a physician organization. Model 3 is initiated either by a post-acute provider, like a home health agency or a SNF, or the physician group can also be the initiator of a Model 3 bundle. In the same scenario, they're either the operating surgeon or the attending physician. Next slide, please. So just a couple other points on Model 2. The distinguishing factor here, as I mentioned, it does include the initial hospitalization and then 30, 60, or 90 days post-discharge, initiated by a hospital or a physician. And in terms of what most costs are included, like I mentioned, there are a few exceptions. So a cancer case or a traumatic event that it would be unrelated to the initial hospitalization would be excluded. Unrelated surgeries are generally excluded. But most readmissions and services that happen to the patient are included, but those clearly unrelated activities would be excluded. Next slide, please. So Model 3 starts after the patient's discharge from the hospital, can be initiated again by the physicians or by the post-acute provider. If it's initiated by a post-acute provider, they only initiate a bundle if they are the first site of service post-discharge. So if a home health agency is participating in the program, then patients discharged from the hospital directly to home health, that would initiate a bundle. If the patient goes to say they go to an LTAC first and then to home health, that would not initiate a bundle for the home health agency. They have to be the first Part A service provider for the patient coming out of the hospital. And in Model 3, most of the savings opportunities, or all the savings opportunities, are in the post-acute setting, and most of them are readmissions, reducing readmissions, and reducing days in the skilled nursing facility. Physicians have the opportunity to help reduce utilization of the skilled nursing facility and reduce length of stay in the skilled nursing facility. The one area of opportunity, or the biggest area of opportunity in Model 2 that doesn't exist in Model 3 would be for those types of procedures that have a high-cost device, such as an implant. If there's opportunity to work with the hospital to achieve savings on the implant costs, then that would be a savings that exists in Model 2 that doesn't exist in Model 3, and that would be a reason for a physician group, for example, to consider pursuing a Model 2 rather than a Model 3. I also want to talk for a moment about funds flow and pricing for how the program works in both Models 2 and Model 3. So in terms of funds flow, everyone will continue to get paid the same way as if they were in Medicare fee-for-service. That doesn't stop, and everyone gets their prevailing Medicare fee-for-service reimbursement during the course of the bundle, including the episode initiator. That won't change. What CMS does is, if you apply to the program, they will create a price specific to your organization. So if you're a physician group, it will be specific to your group. If you're a hospital, it will be specific to your hospital. And they'll create a price for each bundle that you apply for. And that price is going to be based on your specific performance during a period of time. And that period is July of 2009 through June of 2012. And so they're going to, so say you choose to participate in major joint procedures. They're going to look at your organization's cost managing, say it's a 60-day bundle. So you do major joint over 60 days. They're going to look at your performance in that period of time, and they're going to look at all the costs associated with your management of major joint patients. So if it's Model 2, they'll look at the hospital costs, SNF, readmits, all those things. And they'll create a baseline. So for this example, for a 60-day major joint procedure, let's call it a $20,000 baseline. If that's your baseline, they're going to take a 3% discount off that baseline, so in this case it would be $600, and they'll quote you a price. So the price will be $19,400. What they will do is, everyone gets paid fee for service. They're going to track the claims for the patient in the bundle, and then at the end, after the bundle is settled, all the claims are paid, they'll do a retrospective reconciliation, and if you manage the cost for $17,000, they'll compare that to your $19,400 price, and they'll cut a check of $2,400 to the owner of the bundle. If the costs are higher and you didn't do a good job of managing the cost and it comes in at $21,000, then the owner of the bundle owes CMS a check for $1,600. So there's real upside opportunity and there's real risk in the program. Let me make one more comment on pricing. So as I said, their goal is to develop a price based on your historical experience with caring for these populations, but they need to do that, they need a sizable enough sample set to create a statistically significant price for your performance, for based on your experience. So, and their goal typically is to get 60 to 100 cases or so to be able to have enough volume to create a price solely based on your performance. If there's not enough sample size for your performance, what they do is they create a weighted average between your historical performance and the statewide mean, for that particular case. So they're going to, if you apply for a bundle, they're going to give you a price. If there's enough volume, that price will be based solely on your history. If there's not enough volume, it'll be based on a weighted average between your history and the statewide mean. They will give you a price in the program, and you get to evaluate that price before you decide to participate. Next slide, please. Okay, so I'll talk a bit about why the opportunities for providers who are participating in Lyme, MedPAC, and New England Journal of Medicine or others, and in CMS, frankly, seem so enthusiastic about this program. One thing I didn't mention, you may know, but this is the 4th time that CMS has opened the window for participants to come into this program. The fact that they've opened it 4 times and they made the application process very straightforward indicates to me that they're looking for this to be a sizable program with many providers participating. Also, frankly, the fact that they're looking for relatively modest discounts, 3%, indicates that they're hoping that the providers will participate and be successful in the program. Next slide, please. So talk a little bit about various payment reform initiatives or payment methodologies. Bundle payment really is designed for specialists, acute and post-acute care providers. So, as you know, many providers, including I'm sure many of you, are working on initiatives to reduce costs, improve care. Almost everyone has some sort of readmission reduction initiative underway. Folks are starting to think about post-acute, managing post-acute costs. So to the extent that you're developing those programs and having some success, if you're in the fee-for-service environment, the reward, the savings you create, the benefit of that goes to the payer, whether in the commercial market, the health plan, or in Medicare at the CMS. So you do the work and the benefit goes to the payer. If there's an ACO in your community and you're doing that work, the benefit of that effort goes to the PCPs or whoever it is who's the driver behind the ACO. And the bundle payment program is really, again, focused on the specialist, acute and post-acute provider, and allows those folks to benefit from the work you're doing and the savings you're experiencing through these care management initiatives. I also want to point out, though, that it doesn't all have to be, every person for themselves. Within the bundle payment program, there's opportunity to share those savings. So if you have success in the program and you have savings, you can share them with your PCP partners or the ACO in your market. You can share them with your hospital or your post-acute providers. What this does is it, gets the specialists and the acute, post-acute folks a seat at the table in payment reform, and then allows you to start collaborating and negotiating with your other provider participants on how to share the dollars and drive the improvements. Carve-outs are coming. Medicare has just recently requested information for the complex and chronic care bundle payment program, and this would be obviously focused on folks with chronic conditions and a bundle over a longer period of time. That will create opportunities for other types of providers to benefit from the care they deliver and the savings they achieve for high-cost complex patients with chronic illnesses or multiple chronic diseases. Next slide, please. Okay, just an overview of the benefits for specialists and acute and post-acute care folks for participating. Some of these I've hit on. Focuses the care and risk management responsibilities on the patient, on the provider with the most influence at that point in time. Provides access to new revenue. There's not a lot of folks providing access to new revenue in today's environment, and so this program does provide access to new revenue if the opportunities are there and it's managed well. Allows the providers who are creating the benefit to capture some of the benefit, create the platform for participation. I talked to a lot of providers who are worried about being vendorized or essentially played against each other for price by providers upstream, whether it's the ACO or other referral sources. This program really allows providers to differentiate themselves on more than price and illustrate the value that they're creating, and partner with folks based on a value proposition rather than just a price proposition. And there are a number of first mover advantages in the program. My view is we're about to enter a period where costs are going to come out of the system, particularly for folks who are focused on it and managing it. And folks who get in early will have the benefit of getting those costs when they're there to be achieved. A couple of years from now, I think it'll be a little harder to keep taking costs out. So getting in early is a benefit. The other advantage is, this is another belief. Some may agree, some may not. But my perspective is, these payment reform initiatives are here to stay. And the earlier folks get in, the more experience you'll have with managing within this environment, and the more competitive edge you'll have over others in the marketplace who may be a little bit further behind. So I think there is good potential for getting in early. But the third is CMS is looking for a 3% discount now. I think there's opportunity to do well with that environment. Down the road, those discounts may be steeper, and so it'll be harder to get savings. And so there's good opportunity to get in now and earn some of those savings while the discounts are in your favor. Next slide, please, Ellen. Okay, another area where MedPAC and others see opportunity in this program and why they're excited about this program. This is a study from MedPAC, and it's looking at a sample of 10 conditions and how much cost is spent in the post-acute setting and how much variability there is in the cost in the post-acute setting. So the blue bars represent, for each of these conditions, the amount of spending on average that happens over a 90-day bundle in the post-acute setting. So, you can see for hip and femur procedures, there's almost $30,000 of cost once the patient's discharged from the hospital in the next 90 days. Some of these others, it's $15,000, $20,000 all the way over to cash, where it's $10,000 of cost in the post-acute setting. Many times when I talk to providers who don't spend a lot of time with the claims data or have the opportunity to look at a lot of the claims data, they're surprised to see how much of the cost is in the post-acute setting. And then the other factor is variability. So the orange line represents, and again, this is from MedPAC, it shows the variability in spending across these conditions, really within these conditions, between the 75th percentile performer and the 25th percentile performer. So in some cases, the ratio is as much as 5 to 1. The 75th percentile performer spending 5 times as much as the 25th percentile performer. And I think MedPAC's view is that where there's high variability and high cost in the post-acute setting, there's opportunity to bring those costs down, smooth that variability, and achieve savings. And providers within the bundle payment program will benefit. CMS gets their 3% discount, so they benefit, and the provider, if they're smoothing that variability, will benefit as well. Next slide, please. So this is essentially just an example or some scenarios around types of savings. The benefit to providers basically are the owner of the bundle, given different savings ranges. So you can see on the left-hand column there, there's the saving ranges ranging from 5 to 20% of the total bundle cost. I'm going to focus on the 10% row here for illustrative purposes. So this assumes a $25,000 total bundle cost, and there's 3% discount to CMS, and then typically there's some costs required to manage care in new ways and work with providers to deliver care management and different types of activities, and essentially manage the patient in new ways. And so some overhead costs will be required. The estimate here is total overhead and CMS discount of 5%. That would mean net upside to the owner of the bundle after all those costs of $1,250 per Medicare fee-for-service inpatient case. So if you think about 10% and you think about what you would need to achieve to get 10% from an operational perspective, it would be about a 2-day combination of these things, about a reduction of about 2-day length of stay in the SNF, 10% reinduction in your readmit rate, and about a 10% reduction in device costs. Now this is, you could have different mixes of those levers there basically, but so there's definitely work to do. Definitely have to think about care management and care design in a different way, but relatively modest improvements yield a 10% savings And so if you had as a group or as a hospital, if you have 100 cases, that would be $125,000 of net upside per year, or over the 3-year course of the CMS contract, that's about $375,000 of net upside after cost. So, and obviously the opportunity goes up with more cases. So significant opportunity for increased revenue for participants in the program who do well and are successful at managing care in new ways. Excuse me, next slide, please.
Okay, so let's pause here and let's do our second poll. All right. So with the information you've heard so far, the question is, do you feel the BPCI would be beneficial to you or to your organization? Yes, no, or not sure? Would you find this program incentive beneficial to you? We got about 70% of the vote in. Wait 5 more seconds. Let's see if we can get everybody in before we share the results. 5, 4, 3, 2, 1, and we'll close the vote and let's share the results. Dave?
Okay. That's helpful. So the not sure piece is helpful. I think, and actually I think fair. I think really the answer depends on what the data shows. And so I'll talk in a moment about the process for participating in the program. But CMS essentially creates, it's a pretty transparent program from CMS's perspective. They share a lot of data, and then you can look at the information and decide whether you based on the prices you've been given and the background data they provide for you for what derives those, the underlying data that derives those prices, you can look at that information and see where the opportunities are and get a better sense of if it's something that would be beneficial for your organization. So that's helpful. Thank you. Okay, next slide, please. Okay, so time for a change. So let's just next slide, please, and I'll walk through the timeline and process for how to get engaged if that's of interest. So as I mentioned in the beginning, there is essentially a non-binding indication of interest due to CMS on April 18th. It's a very straightforward process. There's essentially a spreadsheet that's required where you need to give your Medicare ID number, tax ID number, contact information, name of organization, and a few other pretty straightforward elements that literally can be done in a couple days. And it's completely non-binding, and again, due to CMS next week. That will then initiate a process. My perspective is some of the work is internal, and some of the work is driven by CMS. The internal work is thinking, and I'm just starting this as soon as possible, but thinking about how you're going to redesign care to manage your patients in a different way to improve on those things that I mentioned earlier. So reducing readmissions, which you may already be working on, protocols for specific types of patients so that you have sort of predetermined care plans for specific type of patients so you know how to reduce that variation, thinking about provider relationships, collaborative relationships you might want to have with other providers along the continuum. Just really thinking about a handful of things that you could do differently to manage care in new ways to prepare to be in a risk environment and maximize your opportunity for success for the program. And I would recommend that starting relatively soon. The other major first step is in early summer. CMS will start sending you data. That data essentially is claims data that shows they call it the non-risk period, and they'll give you basically hypothetical bundled data as if you were in the program, and you can look at that information to see how you're performing, where the costs are, and what opportunities you might have for thinking about improvement. That'll start coming to you in July. And then late summer, early fall, CMS will give you the pricing data. And so for all the bundles you apply for, based on, again, that formula I described before, hopefully based mainly on your own historical experience, they'll give you prices for each bundle that you apply for. And even if you have small volume in a bundle, they will give you a price. Along with those prices, they'll give you all the data they use to develop those prices. And that data can be very illuminating. Providers often don't have a lot of chance to look at claims data, but this is an opportunity to look at claims data, look at the makeup of those prices. So if you apply for major joint procedures, you'll see how much of the cost is in the hospital, how much of the cost is physician services, how much of the cost is readmission, and you'll be able to see that type of information. There's also an opportunity to compare that data to how others are performing and to assess where the opportunities may be. Then in mid-fall is when decisions need to be made. Again, this is non-binding. So if you look at the data and you say this is not attractive or we're not something we're interested in, you have no obligation to proceed. But if you want to proceed in mid-fall, you'll need to select the bundles based on the data analysis. Select the bundles you want to participate in, and submit that information to CMS. There's also a number of other filings that need to be submitted to CMS. Something called the implementation protocol, which outlines your care model redesign plans, and I think I mentioned you're allowed to gain share in this program, which means that you can share savings with other providers along the continuum and really align incentives for driving improvement. In the fall, you'll need to submit your plans for how you're going to gain share and who you want to be working with from a gain share perspective. And then also in the fall is when you would execute a contract either directly with CMS or with an awardee convener or other player you may be participating in to help you get into the program. So that, in terms of the contract, it is a 3-year contract for the program. But again, CMS has created significant flexibility. So for folks who get into the program and they decide it's not working out, you can decide to get out of the program and just give CMS 60 days notice. If it's going really well and you want to add bundles, you can add bundles. Say you started with 10 and you want to add more, you can add more bundles. You say it's going well for 8 of the 10 bundles you put in for, but 2 bundles, CHF, COPD, for example, aren't going well, you can drop bundles on a quarterly basis. So there's lots of flexibility for getting in and getting out and for expanding the size of your program, shrinking the size of your program. So it's quite attractive, both from a transparency perspective and from a risk management perspective, given the flexibility that CMS has created within the program. So those decisions and contracting activities will happen in the fall, and then the program starts on January 1st. In the fall will be a fair amount of activity getting ready on submitting the information to CMS and thinking about implementing the care model redesign plans that you've been working on, hopefully since the spring. So that's a bit about the process. I want to be clear, there is a fair amount of work involved, but the initial application that's due next week is very straightforward and essentially gets you a placeholder, allows you to review the data, and then decide down the road how you want to participate. With that, I'll stop. I think we may have another poll.
We do. We have our last poll. Thank you, Dave. So the last question that we're going to launch to everyone is, given the information that Dave just shared, will you consider registering for the CMS BPCI program to review your bundled pricing data? And the response choices are yes, no, or possibly. With what you've just heard about it, will you consider registering for this program? We've got about 72% voted. Let's give it another 5 seconds. 4, 3, 2, 1. We'll close the poll and let's share the results. Dave?
Okay, great. So it continues the theme of some uncertainty, which is understandable. I would advocate at least considering it, only because it does. It's a non-binding option, and it gets you the information you can decide down the road. But obviously, there's a number of considerations as you think about that. Okay, next slide, please. So this is my last slide, and then we can go to Q&A. Next steps are pretty straightforward. Based, just as the last poll asked, just sort of assess you're interested in applying. If you are interested, initiate the data application collection, the data collection process. Excuse me. As I mentioned, it's pretty straightforward. and then file the application by next Friday, and then initiate the planning process as I described for care model redesign and sort of getting ready to receive the data and those types of things. So a relatively straightforward set of next steps, and with that, I think we'll pause and take questions. I know I ran through a lot of information pretty quickly, but happy to either take questions now, or our contact information is here. Happy to take questions individually if that would be helpful as well.
All right, Dave, we do have quite a few questions that have been submitted, and just a reminder to everyone as we start posing these questions to Dave, if you have any that come up, put them into that questions window. If we don't get to them during this live presentation, we will follow up with you following the session. Okay, so let's start. The first question we've got, Dave, is there a minimum size for physician group which would apply?
No. I mean, there's no minimum size from CMS's perspective, and I encourage physician groups to apply, particularly groups that have a decent amount of inpatient volume and hospital inpatient volume, either where you're the surgeon or the attending. You've got a decent amount of volume there. There's no minimum to apply. I think when you get the data, you're going to want to evaluate the opportunity. There is benefit in scale. So even if you're a small group, there are ways to combine the risk profile with other groups and sort of smooth the volatility a bit. So I particularly physician groups that have a decent amount of volume on the inpatient side, I encourage you to apply, even if you're a small group, because there can be real upside and there are ways to protect on the downside.
Okay. Dave, we have actually two small follow-up questions to that one. Is there a cost to apply?
There is no cost to CMS to apply.
Okay.
My organization works with providers to help them apply, and there can be fees associated with doing that, but folks can apply on their own. There's no cost to CMS to apply. And then the next step is to think about how you want to evaluate the program, and there are organizations out there that can help you do that.
Okay. And is there a template then for the type of information that CMS requires in order to submit an application before the 18th?
Yes, there is, and I'd be happy, Ellen, if there's a way to do this through your website or somehow, or you just sending emails out to folks, I'd be happy to share the application template from CMS with folks, and I can either send out directly. If people want to put in a specific request for that, we can respond with an email with the
link.
Attachment. Yeah.
Perfect. That's what we'll do. We'll include it in the follow-up. Okay. All right. Next question. What infrastructure should be developed now to be ready for the data analysis?
In terms of the data analysis, this is pretty deep dive claims data analytics. So, getting some help on that front, I think is many providers don't have the infrastructure to do the claims data analysis. So, to the extent that you want to do price comparisons and those types of things, you may need some external help. In terms of receiving so there's several different types of data that you'll receive. One is you're going to receive claims data feeds from CMS on your bundle performance. And so that you probably want to work with a third party on receiving that information and analyzing that information. You're going to receive pricing sheets from CMS that describe the prices that they've quoted you. And that information can be reviewed just by looking at the sheet and looking at the prices, but you may want some assistance in doing some benchmarking and some analysis of those prices. In terms of other infrastructure, I mean, a major part of this is, some of this is things I'm sure you're already involved with on care model redesign. And so, working with your care management team and case managers and other folks like that who you may have relationships with, to think about, again, the activities you want to be involved with to improve the transition from hospital to home, and think about care coordination. So there definitely be some care coordination infrastructure that would be helpful.
Okay. All right. Next question. If the application is so simple, on what basis will applications be approved or denied, or will they all be approved?
Yeah, good question. I'm not aware of folks being denied. I think initially, I may have mentioned in the very first application process in 2012, it was very arduous, many questions, very challenging application to fill out, and a lot of work for the applicants. It was a lot of work for CMS applications, and I don't believe they were denied anybody through that process. I could be wrong about that, but I haven't heard of anyone being denied. I think basically they want providers to come into the program. They want providers to do their own assessment of how they want to participate, and you know they may deny if someone has some sort of is run afoul of CMS some way through some sort of investigation or something like that. But I'm not familiar with them denying, and it's really an assessment process on the provider side to decide, if you want to participate in the best way you want to participate.
Okay. All right.
That's what I sort of even call it. I think they call it an application. I consider it more an indication of interest, frankly, in this next round.
Okay. All right. Do you see any major risk in initial participation in BPCI?
I see no risk in applying on the 18th, getting your data, and evaluating going forward. It's completely non-binding. It's just a way to get information, very rich and illuminating data about your performance history within this bundle structure, and it's a tremendous way to learn. There may be, if you work with a third party to help you evaluate that, there are costs associated with that. So there may be some, that's a risk, that's a cost, but you can evaluate that as you go. But other than that, there's really no downside.
Excellent. Okay, so there's really no risk to at least getting the application in by April 18th.
I completely agree with that.
Yep. Okay. All right. What happens if a physician group and a hospital both participate in the bundled payment program?
Yes. Good question. So CMS has published essentially a methodology for how they think about this. So if a physician it's a little complicated, but if a physician initiates a bundle and they do the surgery at a hospital that is also doing bundles, the physician will supersede the hospital. There is one exception to that CMS recently published, which is that if the hospital got into the program first, then the hospital bundle will supersede the physician. So if they both come in at the same time, the physician supersedes the hospital, but there is some acknowledgement of precedent for coming into the program or timing for when folks came into the program. If a hospital initiates a bundle and then refers a patient to a SNF, say, who is participating in the program, the hospital will supersede the SNF. So it's sort of, follows the referral chain. Physician supersedes hospital, hospital supersedes post-acute provider.
Okay. All right. How do the Medicare bundled payment program and the ACO program interact? Good question.
Yes, another good question. So the bundle payment program essentially becomes like a carve-out to the ACO. So in that example, in that instance, the ACO will essentially get the benefit of the 3% discount, and then all of the care management and risk management responsibilities fall to the owner of the bundle. So to say back to that major joint example that I gave, where it was a $20,000 baseline price, a baseline cost, and the price was the CMS quote was $19,400. So in that example, the ACO will get the benefit of that $600 savings of 3%, and now the specialist, if this is a physician-driven bundle, the surgeon will be responsible for managing that $19,400 bundle, and if they get savings, they can keep them. If they have costs, they owe CMS the difference. If they exceed that $19,400 price, they owe CMS the difference. However, the owner of the bundle can gain share back with the ACO. So, some cases ACOs may see this as threatening, you know, frankly, I think the way I think about it is by creating incentives for the specialist or the acute care provider to focus on improving quality, reducing costs, gives them new incentives to do that and think differently about that. You know, when I managed in the capitated environment, it was very hard for the primary care docs to get the specialists to engage, and this program does that directly. It gives them direct upside for being more proactive in the care management. And so the specialist is more engaged. They can share some of that upside back with the ACO. I've talked to some ACOs who are uncomfortable with this and want to keep it all for themselves. And my response to that is, geez, that sort of enables you to keep the whole pie, but it keeps the pie much smaller. If you share, I think the pie will get bigger, and you know, you won't get to keep all of it, but your slice of it will be bigger if you're working in a program like this. I rambled a little bit, but I hope that was helpful.
Okay, no, great answer. All right, I know that if anyone out there does have additional questions, there's a few that we'll be following up just because of the specificity. Dave will follow up specifically to some of the questions following the session. But if anyone does have any other questions, we do just have a couple of more minutes. You can submit them and we'll follow up afterwards. I do want to keep on schedule, so we'll start to wrap up our session. And I want to start that by thanking Dave very much for the great information on BPCI. The April 18th deadline date for registering or applying is next Friday, a week from Friday, so it is a time sensitive, and as Dave explained, there's really no risk to apply and get back that data analysis to see how it can impact your payments. With so many changes in the payment models today, every piece of knowledge is important, and it's important for everyone to take advantage of every avenue that's available from a payment standpoint. So again, thank you, Dave, for the great information on BPCI.
Thank you, Ellen, for the opportunity. I really appreciate it.
You're welcome. I do want to close with a quick note about MD Everywhere. With our ICD-10 ready, and we kind of, you know, we're ICD-10 ready, even if it's been postponed a tad. We do provide an ICD-10 ready, purpose-built revenue cycle management system and a full suite of claims processing and back-end services for physicians. It's integrated, fully integrated to a 2014 certified EHR solution. And we truly are positioned as a leading single source solution for all of your revenue cycle and EMR needs. Our solutions are designed to aid clients in meeting today's guidelines, the changing guidelines, and also maximizing revenue for all their patient visits. For those who may not be aware, we also have an NCQA certified CVO and credentialing team, making us a full service company with a client base across all our product lines nationwide. We service approximately 7,000 physicians, 40 different specialties, and we can work with solo providers, mid to large size groups. We have ACOs, as well as hospital organizations, faculty practice groups, and we help them all with their RCM, EMR, and credentialing needs. Today's viewers are welcome to contact MD Everywhere directly with any questions, or if for more information about our services, visit our website, or you can contact us at questions@mdeverywhere.com, and I'm sorry, okay, at questions@mdeverywhere.com, as well as by visiting the MD Everywhere website at mdeverywhere.com. Keep in mind that with the challenges that are being presented as part of healthcare reform, it is important to work with a partner who can help you navigate these changes successfully and with flexibility, and MD Everywhere is one of those companies. All right, so whether it's 2014 or 2015, we've already completed our CMS ICD-10 claim submission with a 100% claim submission rate, and we'll continue to work with our clients as they prepare for that transition, as well as anything else that gets thrown at us in the next 18 plus months. Again, we'll follow up with the submitted questions after the webinar that we didn't address live on the call. Everyone will receive a link to the webinar will be posted. A recording of the webinar will be posted on the website, and an email will be sent out with a link to that recorded for anyone to access at their leisure. We do have a couple of other topics scheduled in the coming weeks. We'll be doing ICD-10 appropriate topic, why the delay doesn't mean you should delay in your preparations. We're also doing a topic on healthcare exchanges, how your patients' options impact you. So keep your eye on the MD Everywhere website, plus watch your emails. We will be sending those dates out shortly. And again, thank you, Dave, for all the great information on BPCI, and thank you to our attendees for taking time out and spending an hour with us today. This does end the webinar, and I hope you all enjoy the rest of your day. Thank you.